Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and Healthline 3 is where we like to focus on ways to help you live a healthier, happier, and pain-free life. We'll be answering any calls and questions that you have in the studio today. Those phone lines are not open just yet. We'll open those in just a couple of minutes, but when you do call, make sure you're in a quiet room with your TV, if you're tuning in on the TV, turned all the way down. That number is 318-219-4569. That number will also be on your screen. And today's topic, we're talking about uterine surgery and cervical procedures. And joining us to talk about this is OBGYN Dr. Karen Berken with Women's Health Associates in Bossier City, a part of Willis-Knighton Health. Thanks so much for being here. And we're going to be talking a lot about minimally invasive surgery techniques.
Absolutely. Good to be here.
Okay, so, and I wanted to say this again because I didn't realize that OBGYNs participated in a lot of the surgical procedures that, you know, in the uterus and I guess in the cervix and whatever else that you need to take care of. I didn't realize that, and I think that we had talked about that at one of our last conversations. So I think that's probably a common misconception, would you say?
It is. I've definitely had people ask me before, you know, what do I do? You know, what does the OB and the GYN actually mean? And the OB stands for obstetrics, which is all related to taking care of pregnant moms and babies. And then the GYN part stands for gynecology, which is non-pregnant surgery, which can include the fallopian tubes, the ovaries, the uterus, the cervix, and any vaginal or, you know, vulvar issue, basically.
Okay, yeah, very interesting. So it covers a lot of different things, and I think a lot of times people just think of the OB part, right?
Absolutely, yeah.
Yeah. Okay, very interesting. So tell us a little bit about this surgical intervention. It's minimally invasive. It starts with an H. I'll let you take it from there.
So hysteroscopic surgery. That prefix means uterus or womb, and so hysteroscopic means basically taking a camera and looking in the uterus or the womb. Traditionally, you know, back in the day, all that we had the ability to do was open surgery. But as technology has gotten better and cameras have gotten much smaller, we've been able to incorporate those in all sorts of different surgical procedures, not just in my specialty. But because the cameras can be basically the size of the tip of a pencil, you can put them on a scope, which then you can use either laparoscopically or hysteroscopically. The difference is laparoscopically you're making small incisions in the abdomen and then placing the camera through those small incisions. Hysteroscopically, you're actually using the natural opening in the cervix to access the uterus, and so you can use that camera to survey the uterus, biopsy any areas, and remove certain tissue or growths that may be causing various issues in the uterus. Because not only do we have the ability to look with a camera, but we also have different surgical devices which then can also be used to remove certain issues and treat certain issues.
Very interesting. So at times do you use the hysteroscopic tool as an avenue of seeing what's going on in the uterus first before you go and do the surgery, or oftentimes are you doing it at the same time?
So you can do it both ways. You know, oftentimes it depends on the reason that we're using the hysteroscope. We even have a hysteroscope that we can use in the office, so you don't even have to go under general anesthesia in order to have this procedure done. And if someone is having difficulty conceiving, one of the things that we can use is the hysteroscope to look and see, is there a growth or a fibroid, a polyp, maybe a septum in the uterus, which a septum is kind of a wall or divide in the uterine cavity that's not supposed to be there. All of these things can either block the fallopian tubes or prevent pregnancies from occurring, but also if a pregnancy happens to implant on a fibroid or a septum, that structure is not built to really sustain and carry a pregnancy. And so the blood supply is not the greatest, and it can lead to a miscarriage if a pregnancy happens to implant on the wrong area. And so we can, if we see something like that on ultrasound, then we can either in the office or in the operating room, we can use a hysteroscope to identify the issue. If it's something small like a polyp, we can potentially remove that even in the office with a small device that we have. If it's a little bit more extensive, we have to remove a larger fibroid, something that may cause bleeding during the procedure, or resect a septum, something of that nature. Then we'll typically reserve the operating room for that, and then we can diagnose and treat the issue in one fell swoop.
Interesting. Okay, and so we talked a little bit in our midday newscast, like some of these conditions, and you mentioned, having difficulty conceiving, fibroids, polyps. Those are some of the things that you would want to maybe pursue this type of surgery for. But anything else that that maybe you didn't mention, or that's a common concern for women?
Yeah, so one of the biggest reasons why someone comes to see me from a gynecological standpoint is heavy periods, painful periods, abnormal uterine bleeding. And a lot of times that's caused by conditions in the uterus, thickened uterine lining, uterine polyps, uterine fibroids. And so you can see some of those things again on ultrasound, but we can go in and actually remove that lining, remove that tissue, or do a more focused removal of a polyp or a fibroid. Another condition that we commonly will do these procedures for is postmenopausal bleeding. So if someone has stopped their period and should never have another period in their life, but all of a sudden their period resumes, or they have an episode of bleeding, that's something that we need to investigate and figure out why. Sometimes we do, again, see a polyp or a fibroid or something that could be causing it. But other times we don't really have a reason, and we can't identify the problem based off of just ultrasound alone. And so doing a hysteroscopic procedure allows us to look in someone's uterus and do a directed sampling of the lining, or biopsy specific areas that may look concerning that otherwise we couldn't see. Because we have a camera at the tip of our instrument, sometimes we'll see an area that may look like it's precancerous or cancerous, and we can take a biopsy and a sample of that area so that we then have tissue that we can diagnose the issue and figure out what needs to be done thereafter.
Okay, very interesting. So in some of those signs and symptoms, like you mentioned, abnormal bleeding, heavy bleeding, does pain typically also come with these issues?
In general, the heavier someone's cycle is, the more painful it's going to be. The uterus is trying to basically cramp and contract to expel that blood, and so the heavier and the more bleeding there is, particularly if someone passes large clots during their cycle, then you'll have more cramping with that.
Mm-hmm. Okay. And the fibroids and polyps, do those sometimes cause pain, or are they kind of benign?
They can be benign or cancerous. There's both types. Polyps in general are typically painless, but they do cause bleeding because they're pretty soft and what we call friable, so they can get jostled easily and bleed easily. But those are typically painless. Fibroids, they're fairly firm, and they're heavy, they can cause pressure symptoms, they bring more blood flow into the uterus, and so fibroids absolutely can cause pain. There's a condition with them as well where they can degenerate, and so they start to outgrow their blood supply, and so they start to essentially kind of die off, and that's extremely painful if someone has a degenerating fibroid.
Okay. So, and that's probably at that point they've already contacted you, and they've probably figured that issue out.
Yeah.
Right, because there's this, unknown pain that's maybe happening outside of their normal periods too.
Right. Yeah.
Okay. And so with this, it's sometimes an outpatient procedure, right? And you said sometimes you don't even have to go into the operating room. However, sometimes you might have to. So the recovery can maybe vary depending on the severity.
The recovery can vary. Now, in general, compared to other forms of surgery, because we're not entering the abdominal or pelvic cavity, we're not placing any incisions. Typically, the recovery, whether you do it in the operating room or in clinic, is pretty quick. Okay. You come in, have the procedure done, you might want to rest that day, but basically the next day you're back to performing your normal daily activities at full capacity. Nice. Oftentimes not really even requiring any form of pain medicine afterwards either. So the recovery is very quick. Really the main difference between the decision to go to the OR versus clinic is how extensive we feel that the procedure might need to be and how comfortable it would be for the patient. If they're having it done in the office, we certainly don't just do the procedure without any pain control. We have pain medication. We have ways to numb the cervix with a local anesthetic. And so we do provide pain control in the office, and oftentimes those pain medications make it to where that person can't drive home until it wears off. But other than that, if we think that we're going to have to do more extensive hysteroscopic surgery to where they might get pretty uncomfortable doing it in the office, then that's where general anesthesia and doing it in the OR really has its role.
Makes sense. Okay. And we've talked about fibroids and polyps, and you mentioned like a thickened lining. Would any of this, or would you be able to do a procedure like this for like endometriosis, or maybe
so not? Endometriosis is basically cells from the uterus that then end up outside of the uterus. So they typically end up by the ovaries, low down in the pelvis. So you can't see any endometriosis doing it hysteroscopically, but laparoscopically, absolutely.
Okay, makes sense.
That's the gold standard to diagnose and to treat endometriosis. Now, there's a condition called adenomyosis, which is where endometriosis is occurring, but it doesn't actually leave the uterus. It more digs into the wall of the uterus itself. And sometimes you can see that. Typically it's seen on ultrasound because you can see this heterogeneous texture and kind of irregular texture of the wall of the uterus. But you can't often see that because when you're placing a camera in the uterus, you're really just looking at that superficial layer. But you can remove a thickened lining, or you can see a thickened lining, and you can remove that and help with postmenopausal bleeding or heavy cycles.
Okay, cool, makes sense. And with the scope that you're using, is this robotically, or how does that typically is it performed?
So laparoscopically, we have a robot that we will use sometimes to do surgery. At this point, hysteroscopically, there's no robotic capabilities. I'm sure there's going to eventually one day be something that comes down the pipeline, but at this point, there's nothing robotic, but basically it is a camera on a long scope, and then you can feed different instruments through the channel in that scope, and so that's how you can remove fibroids or polyps or do biopsies. You can cauterize different structures if you're having bleeding. You can inject some medication if you need to through a device. And all of that is basically done with me holding a camera, or an OBGYN holding the camera and the scope, and then using my other hand to operate and feed instruments in and out. Sometimes you wish you had more than two hands, but you make do.
Okay, very interesting. So, yeah, and again, that's something that you would want to get established care with, maybe in that first session with a OBGYN. You would talk about the symptoms, and then from there, do you kind of have an idea of what some people are struggling with, or does the ultrasound really help you to fully diagnose the problem?
Ultrasound is a very useful tool. order ultrasounds all the time, to the point that we have 2 full ultrasound machines, 2 full ultrasound techs that are in our office at all times. And they're not only doing pregnancy scans, but also scans for non-pregnant patients. So ultrasound is a very useful tool, but the hysteroscopic capabilities in the office are also very useful. Because for fertility, for example, sometimes we get an ultrasound, and because it's only a 2D image, you don't get the best views sometimes of the uterus as a whole. So you're trying to piece together 2-dimensional images sometimes. Now there's some 3D capabilities, 3D and 4D capabilities with an ultrasound, but they're not perfect. And so if you're suspicious of something like a uterine septum that might be causing issues with someone getting pregnant, then being able to do a quick and simple hysteroscopic look into the uterus in the office is a really, really good diagnostic tool that we have.
Okay, yeah, and that could give a lot of people peace of mind, you know. And so with fertility, since we're kind of on this topic, what do you typically tell patients when they should worry? If they're, you know, maybe trying to conceive, when should they begin to worry that they are actually having troubles? Because sometimes it does just maybe take a couple of months.
It does, yeah. Despite us all knowing people that can look at someone across the room and get pregnant, you know, that's not the case for everybody. Most people have about a 20% chance per month to get pregnant if there's no barriers to fertility. So when you think about it, that's actually pretty low.
It is, yeah.
And so if someone is under the age of 35 and is trying to have a baby, and they have not conceived within 1 year of actively trying, then that's when we start to do a workup typically. And then if someone is 35 or older, we tend to shorten that time frame to about 6 months, mainly because we don't want to delay an important workup and an important find, and delay someone's ability to conceive too long once you're over the age of 35, because we do know that starting anytime after 40, it's normal if menopausal changes do start to happen. And so we tend to shorten that time frame so that we can get a diagnosis and get that treated and get them on their way to a successful pregnancy more quickly.
Makes sense. Okay. And so we talked about like the uterine problems, and then also with, you know, you also do a pap smear on patients, and that's would be more like the cervical issues, right? So can you talk about when should someone start their pap smears and what you're looking for when you do that, and we can kind of go into that thought process.
Yeah, so pap smears depend on what source you read, but I typically start pap smears at age 21. And you don't technically need a pap smear every single year by the newer guidelines. A lot of patients still want them every year, and they are covered by insurance every year all the way up until someone's of Medicare age. But when you have a pap smear done, it's a screening for cervical cancer. And we have the ability to do a vaginal exam, use a brush to get a very superficial sample of cells from the outside of someone's cervix. That's then read and reports out a normal pap smear, an abnormal pap smear, and if it's abnormal, then oftentimes there's something called HPV testing, which is done, which that stands for human papillomavirus, which is the causative virus for most cervical cancers. And so if someone has a low grade or a high grade or kind of atypical pap smear, then the HPV testing will also be done on that sample, and based off of what the result is, then we have certain algorithms and guidelines to follow to indicate what's needed next as the next step. So if someone's normal, then they don't need to worry about it and they're good until their next annual exam. If something comes back abnormal and needs additional workup, then we do something called a colposcopy. which is done in the office. There's really no downtime associated with a colposcopy, but it's just taking a closer look at someone's cervix. We have a special solution and a special microscope that can identify abnormalities that you can see to the naked eye with the help of this microscope. And if you see any areas, then you take a biopsy of those areas and then you send them off. Because what truly determines how abnormal someone's cervix is really how deep the abnormality goes. So when you do a pap smear and you're just getting that superficial layer of cells, you don't know how deep that abnormality goes. So then you do the colposcopy and you have the biopsies done, and if the biopsies come back as a higher grade abnormality, then there's a further procedure that needs to be done. Those procedures are excisional procedures where you actually remove a piece of the cervix to get rid of that issue. And that can, again, be done in the operating room or in the office. We have both of those capabilities. And the two procedures are called a leap or a cone. Leap is where you have a wire loop that has an electrical current that runs through it that can cauterize and cut through tissue. And so we numb the cervix and get the patient some good pain control, and then we use that wire loop to remove the abnormal area of the cervix. We don't want to remove any more tissue than we need to, but we remove that abnormal area and then send the tissue off. And the pathologist will look at it and tell us, this was the abnormality that was present, and it was all removed, and the margins of that excisional piece are clear. And so then we know that we got it all. And then we just resume normal screening for that patient. And so then they would come back the following year for another pap smear. If someone wants to do the cone procedure, then that's in the operating room typically, and that's where you remove instead of using a wire loop to remove kind of a superficial section of the cervix, you remove a cone-shaped piece and then send that off. So that's a little bit more involved, and so we typically do that one in the operating room.
Gotcha. Okay. And so just because you get the abnormal pap smear results, does that always mean that you have cancer, or just means that you want to look into it a little bit deeper?
You typically just want to look into it a little bit deeper. Pap smears, believe it or not, sometimes they do actually find cancer. They'll result that a cancer has been found. But that's pretty rare. Most commonly, they come back as either a low or a high grade abnormality, and then based off of the person's age and risk factors and what abnormality was found, then that dictates the next step and determines whether the colposcopy is appropriate. And then the colposcopy, sometimes that's all someone needs, and then if they need something further, then that's when they have the bigger procedure done.
Okay. Well, we do have our first caller. Eileen, thanks for joining us, and what is your question for Dr. Berken?
Yes, ma'am. I just need to ask, if you've had a total hysterectomy, do you still have to have pap smears?
That's a great question. I get that question all the time. And it depends. It's a little bit of a complicated answer. So if someone has had routine screening, so they have come for their pap smears and they have never had an abnormal pap smear, then once you have a hysterectomy, you never need another pap smear again. But if you've had a history of abnormal pap smears or treatment to your cervix, and then you have had a hysterectomy, because that HPV virus can still cause changes to the vaginal cells and the vulvar cells, it is recommended that if you've had abnormals, then you do continue to have pap smears even after a hysterectomy. But that's a great question. I get it all the time. And there's some patients that are just so in the routine of getting pap smears that even after a hysterectomy, they still prefer to have them done, and insurance still covers them. So I always give patients the option. I tell them, you don't necessarily need this, but it will be included in your preventative benefits, and if you prefer to have it done, I'm doing an exam anyway, so we can absolutely collect it.
Okay, good question. Thanks, Eileen. And we have
Thank you, and God bless you.
Absolutely. So with the pap smear, Let me think. What was my question? It does cause a little bit of spotting, right? So that could potentially, right?
Okay.
So that could be something that, if somebody notices that right after, especially if they're pregnant, like that might be something that they want to know up front,
Yes.
instead of being shocked, like, oh no, what's going on? Am I having issues with the pregnancy, right?
Yeah, no, and pap smears, because the cells of the cervix are often pretty soft and again pretty friable, that using the brush can certainly stir up just a little bit of spotting. Now, if it's heavy, consistent with a period or something like that, that's a little bit more than expected, and so that would be something abnormal. But I typically tell patients, you may experience a little bit of spotting after this. Don't worry about it. That's okay. And then after certain uterine procedures or cervical procedures, you can experience spotting. Typically it starts out kind of more reddish, more fresh, and then it'll turn to more of kind of an older, blood brownish color. Certain different discharges as things are healing. Certainly if you have a procedure on the inside of your uterus, that's a tissue surface just like any other part of your body, and so it does need to heal, and in that process, you can experience different symptoms. So we typically warn patients, about what to expect and what's normal, and then what's concerning, so that they know what they need to call for if they have a red flag.
And the HPV is virus. This is what we're concerned about, right? That could potentially lead to cervical cancer. Isn't there a vaccine that you can get?
There is.
Okay. Is that recommended still? It's recommended in young kids, right? I'm forgetting.
No, you're on the right track. So yes, there is a vaccine. It's called Gardasil.
Okay.
And currently, the version that we have covers the 9 worst strains of the HPV virus. Now, there are hundreds of strains out there, and the vaccine covers the 9 worst strains that we know are most likely to cause actual cancer.
Okay.
And so the vaccine's recommended really starting as young as age 9, all the way up until now. It used to be 27, now it's 45. But I talk to a lot of patients about the vaccine because HPV is so prevalent. It's so common. You think we get vaccines for measles and mumps and rubella and all of these different conditions, but how frequently have you ever met someone that actually had the measles? Not very commonly, and that's because the vaccines have worked. But HPV, by the time someone's 30, about 80 to 90% of females have been exposed to HPV. Wow. And so we stress the importance of the vaccine. It's something that I talk to my young patients about when they come in for annual visits. And it's depending on the age that you are when you want it, it's either 2 or a series of 3 shots. It does make your arm a little sore. I've gotten it myself. But once you finish the series, then you're covered. And at this point, there's no boosters or anything that you need to get. Like I said, it used to be age 27 was the upper limit when you could get it. Now they've extended it to 45. But I've even administered the vaccine and gotten it covered by insurance for people over age 45 because really if someone's entered back into the dating scene, then they could potentially be exposed again. And so, now that, if patients are have a new exposure or potential for a new exposure, then they would potentially qualify and could benefit from the vaccine.
And last question, if someone has had the vaccine, they still need the pap smear each year? Right?
Yes, they still need the pap smear. They are much less likely to ever have an abnormal pap smear because they're protected against the worst strains of the virus. But there's hundreds of versions out there, and pap smears are able to detect the worst strains, but then all of the other HPV strains are typically just reported out as one of the other strains. And so you can have a pap smear that results as a low-grade abnormality, but positive for one of those other strains of the virus, and it's still recommended to do a colposcopy and to look further into the abnormality if that's the case.
All right, good information. We are out of time, unfortunately, but if somebody wanted to establish care with you, Dr. Berken, where can they find you, and do you have that phone number?
Yeah, so I'm at Willis Knight in Bossier, which is right off of 220 in Bossier City. We're Suite 240, so it's 2400 Hospital Drive, Suite 240, and the phone number to reach the clinic is 212-318-7931.
All right, thanks for joining us, and thank you for watching. If you missed this or wanted to rewatch, it'll be on our website, ktbs.com/podcast, or also on Spotify.